Good afternoon. I warmly welcome everyone to the first ERA ESPN-YPNN joint e-seminar. I'm Orsolya Cseprekál from Hungary, the Vice Chair of the European Renal Association Young Nephrologist Platform. And the special feature of today is that we aim to deal with one of the most important topic of the interdisciplinary era of adult and pediatric medicine. And this is the transition, which is supposed to be the most crucial point during our patient care. So we have special thanks for the ERA for letting me have the opportunity to give this e-seminar. I would also like to thank all the speakers and the panelists for the incredible dedication in preparing for today. So our speakers will be, and I warmly welcome also our speakers, which they will be Esther Meijer, professor from the Netherlands, Professor Djalila Mekahli from Belgium, and I also warmly welcome Holly Finch from the UK, who represents the patient side during this e-seminar. So I also welcome our panelists, Fabio Paglialonga from Italy, from the ESPN-YPNN board. And unfortunately, our other panelists cannot be here today, Eva Pawłowicz from Poland, but we really warmly thank her for their huge effort for this e-seminar. So today, we will help us to seek for the answers for the most important questions. I believe that we can count on the active participation of the audience, so I would like to encourage everyone to ask their questions arisen during the e-seminar in the Q&A box. And now let me just pass the word to my organizing partner, Evgenia Preka from the UK, to open the seminar on behalf of the ESPN-YPNN also. And I wish you all of you a useful seminar and discussion today on the topic of ADPKD from childhood to adult care, including patient's perspective. Thank you. Please, Jenny.
Thank you very much, Orsi. It's a real pleasure to co-organize this important e-seminar with you, the young adult nephrologist from ERA. And on behalf of all ESPN community, I would like to thank you again for hosting this event and welcoming us. So for our audience information, this is the first ERA ESPN e-seminar hosting a patient's perspective. And for this, I would like to firstly introduce Holly Elizabeth Finch, one of my patients here in UK, who kindly agreed to participate and share her own experience. And thank you again, Holly, for being with us. And then I would like to quickly touch some words about that. So patients and family-centered care is changing the way we provide medical care, increasing both staff satisfaction and, of course, improving patients' outcomes. Medical care continues to become more collaborative with a holistic focus for patients and their source of support, which is their families, something that is no longer just a pediatrician task, but applies to patients of all ages and can be practiced in any healthcare setting, I think. Promoting that patient-centered care is only feasible by giving patients control and voice, customizing care according to their needs and values, and providing information to the patients and their families. Important steps towards this direction is good communication and collaboration. And that's why we're all here today, clinicians and our patient Holly from the UK. And I would like to thank all of you guys once again. Last but not least, I would like to mention that all of us here today believe that involving patients in medical talks promote health literacy and improves medical outcomes in a very professional and respectful relationship with them, incorporating their preferences, their values in our core goals and plans. Thank you very much for hearing this small introduction, and I hope you will enjoy the seminar. Now the words to you, Fabio.
Thank you, Jenny, and good afternoon, everybody. First of all, let me tell you something about the structure of the seminar of today. The whole seminar will be based on some questions, 3 questions, that we may ask ourselves in everyday practice while caring for patients with ADPKD. But first of all, we will ask you to share your opinions on particular clinical problems, and then each question will be discussed with our experts. And we will also have the opportunity to listen to the patient's perspective. Just to start, to introduce you to our polling system and to find out who is with us today, I will start with the first question, just to know who you are. And so the question is, are you participating in this webinar as a patient or a patient's relative, as an adult nephrologist, or maybe as a pediatrician or pediatric nephrologist or other? So please tell us who you are. Okay, so adult nephrologists 48% and pediatricians 43%, and very well, perfect. So let's start. And okay, our first question concerns the screen for ADPKD in an asymptomatic subject, a child or an adult with a family history, or positive family history for ADPKD. So, would you recommend to screen for ADPKD in an asymptomatic relative? You can choose between 4 options. No, ADPKD patients do not need to follow up until they become symptomatic. No, there are no validated screening methods in ADPKD. Or yes, some ADPKD patients could benefit from follow-up in early stages. Or yes, all patients at risk for ADPKD need to be diagnosed at early stages. So please make your choice. Well, 43% yes, some ADPKD patients could benefit from follow-up, and 55% all patients at risk should be diagnosed at early stages. So we need now the opinions by our speakers, and I would start with Esther. So please, Esther, the word is up to you.
Thank you very much, Fabio. And yeah, well, I'm interested to hear that a large amount of you think that ADPKD should be screened in early stages. Actually, about half of you thought that. Well, just to give you some thoughts on the opposite side. My name, by the way, is Esther Meijer. I'm an adult nephrologist working in Groningen. I think we have around 300, 400 ADPKD patients in our outpatient clinic. And at the outpatient clinic, I get a lot of time the question, we have children, do you recommend to screen them? So this is an issue I think that's really important for patients and something we should think about. And I think there are also reasons not to screen in an early stage. And of course, it depends on what you call early, but I would call that younger than 18 years. I think the chances of changing management are very low at an early age. Also, at a low age, the sensitivity is low. And I put here a graph where you can find that, especially if the disease is mild and there's a PKD2 mutation, if you do not find anything on ultrasound, the patient still can have ADPKD. There are consequences for life insurance if you want to buy a house, if you want to have big decisions, maybe later on that you do not know when you're 15 or 16 or so. You have to think about that when you want to do screening. And I also think it's important for a patient to decide also for themselves. It's harder if the parent makes a decision for a child. So I definitely think there are a lot of reasons why you can also not screen a patient. And then next slide, Fabio. Yeah. Obviously, there are also reasons to do it, especially if the disease is severe and you think about treatment with, for instance, tolvaptan, which we won't start before 18 years, but at 18 years, it's an argument to know it early on, because the earlier the treatment starts, obviously, the more effective it is. Some patients feel the feeling of relief if they don't have the disease, but also if they have the disease, because the insecurity can be really hard. maybe patients can make better lifestyle choices. It could have decisions for family planning later on. And also in the case of a living kidney donation, of course, you want to know whether you have ADPKD or not. So in general, I think the patient should decide for themselves if they want to be screened or not. And the role for the physician is to give them counseling and give them arguments why they should or should not do it. So if you ask my personal opinion for this question, I would go for answer number 3, that there are instances when screening can be useful.
Thank you, Esther. And let's move with the opinion of the pediatric nephrologist. So Djalila, please.
First of all, I would like really to say that I am honored to be here with you as a first e-seminar that you highlighted the need of ADPKD between pediatric and adult nephrologists, as I think it is very, very important to help counseling these families of the most important genetic renal disease leading to end-stage renal disease. So for my opinion, I would like to use this algorithm that we published recently in Pediatric Nephrologist with Charlotte Schimpel and Carson Bergman, when we tried actually to make a simple algorithm to help clinicians in their daily practice, and actually what I am using in my dedicated ADPKD clinic. So from the right side, I'm gonna not through because these are children who are presented to our pediatric clinic or emergency with really symptom, and when the diagnosis is already made because they have an incidental finding on ultrasound. I would like to focus on the left side, what we are doing and what we recommend to do with children asymptomatic but at risk having the disease. And I would agree totally with Esther that I think the first step in this is having a clear discussion with the parents, explaining very well the pros and the contra of this screening. And I would really recommend to involve the child if he is mature and if he can discuss. He needs really to have destroyed. And I have in my daily clinic adolescents of 15 years who have their own opinion and would like or not to be screened. And I think they need really to have also their own decision on that. And on making screening in minors, I think I discussed the 2 points: the genetic screening and the imaging screening and the diagnostic screening. So the genetic screening, it is really unethical to have a genetic screening of an asymptomatic minors for an untreatable adult onset disease in general. However, it is completely accepted to do a genetic testing in a minor by the societies of human genetics if there is a treatment available during childhood. However, I think ADPKD don't really fulfill these criteria, because lots of children have actually signs of hypertension or proteinuria, but they don't have subjective symptoms. And I think that we can actually treat these subjective criteria like hypertension, which we might change the long-term follow-up, as it is known that cardiovascular disease is the main cause of mortality in this population. So I think that we can screen for this comorbidity without even uncovering the transmission status of the child. And this can be done either with genetic testing or with ultrasound, and this is mainly if the genetic testing is available in the country or not. However, I discussed the possibility to just have a diagnostic screening by actually measuring the blood pressure and doing a urinary test for proteinuria without doing any ultrasound and without doing any genetic testing. One of the main discussion that I open with them is indeed the legal consequences of this screening, but this differs from country to country. And I can speak about Belgium, but when we wrote this paper with Charlotte, we saw also that the same was in Germany or in a few other countries, that actually the genetic tests are not obliged to withdraw for your when you do insurance policy. However, imaging you have to. So sometimes we think to do genetic screening as a priority and not an ultrasound, just to respect these legal consequences and to avoid them. So when the parent and the child decide, we need, like Esther highlighted, to respect their choice and to go through the final decision, because indeed some families have really psychological burden of uncertainty, and each child have 50% chance to have the disease, but he have also 50% chance being unaffected, and then they can relieve the stress of having the disease. And as last word, if they decide not to screen genetic or imaging, neither screen for hypertension or proteinuria, I really recommend to counsel an adult colleague when the minor becomes an adult, and then they can decide by themselves.
Thank you so much. And now I would like to ask Holly if she has some comments about that. But first of all, please let me thank Holly for joining us today. It's really important for us to have you here today. Thank you.
Thank you. So in terms of my opinions, I completely agree with both of the previous speakers. I think it's really important that it's not forced upon you to find out. I think it should be an open discussion with the family, something that they decide themselves. So from my own personal experience, my mum has ADPKD. My sister and I both got tested when we were 25. We only got tested because we were tested to see if we could be donors for my mum when she had her kidney transplant. I have it, my sister doesn't. It's not really something that my sister has ever thought about getting tested for again until she had a son. And now he's 4 years old and she's thinking about whether or not to get him tested at a young age or not. My mum decided not to for me and my sister because of, we had very little, well, I had a few problems with UTIs when I was younger, but nothing really apart from that, never any hypertension or anything. So she decided not to get us tested, to let us live our lives, see what happens when we're adults. But my sister is going for the opposite now. She's thinking about having her son tested just to see, because she knows that me and my mum have both suffered. So I think at the end of the day, it's completely personal choice. I don't think it should have to be tested. In fact, when I was at university, I was suffering quite badly with UTIs quite regularly. And one of the nurses there really tried to push to me, get tested, get tested, get tested. And it actually started to make me feel a bit uncomfortable. It's my decision. It's up to me whether I want to have a test or not. So yeah, I think it's all about open discussion, going through pros and cons and what the outcomes might be.
Sorry, thank you so much, Holly. That's important for us. And now we can move to the second question, which is important as well. We would like to talk about pre-implantation genetic diagnosis. And the question is, would you inform your ADPKD patient on the possibility of pre-implantation genetic diagnosis. Yes, I have to inform all my ADPKD patients about PJD and help them in the family planning. Or yes, but only if the affected ADPKD patient is a male, as it is contraindicated in ADPKD women. No, PJD is not recommended in ADPKD. Or last, no, this is not the role of the pediatric or adult nephrologist. So let's make your choice. Okay. Oh, more than half of you think that yes, it's important to inform all the patients about this issue and help them in their family planning. And this is the answer, the majority of yes. So I think it's important now to look at what is the opinion of our speakers. And I would start with Esther, the adult nephrology perspective.
Thank you. Yeah, here's a slide just to remind us again of what exactly is done. So there is this procedure where there is, after a cellular biopsy, genetic analysis performed, and you transfer back only the embryos without the PKD mutation. So that's what we are talking about here. Can you, yeah, perfect. So in general, I think it is important to counsel all men, but especially women with a chronic kidney disease who wants to become pregnant, because of both the risk for the mother, but also the risk for the baby. And here below you see a graph of women with who had chronic kidney disease in blue, and women who don't have chronic kidney disease in red. And you see that any stage of chronic kidney disease largely elevates the risk of having preeclampsia, an early birth, a low birth weight, and also intrauterine fetal death. So it's important to notice, I think, for the mother also to make a choice about pregnancy. And if you zoom further in, it is also the case that the more severe your kidney disease, the higher the risk. And also, as you can see on the right, the higher the chance of a decrease in your own kidney function after conception. So in general, it's important, I think, to counsel in pregnancy. And I think it depends on your clinic how you organize this. Maybe you can do it at your own outpatient clinic if you have the time, or you can maybe refer women with these questions to a colleague or a clinical geneticist, or however you make these agreements in your hospital. Then if you zoom in further on ADPKD, which is the question right now, I think apart from counseling pregnancy in chronic kidney disease, there are some additional issues that I think should be discussed. And these are obviously the chance of the child having ADPKD. If you look at that, maybe PGD is an option. So I think it should be mentioned so the patient can make a decision for herself. In the question also, it was stated that as a female patient, you can better not do it. I think that was option 2. Or you could think there are a lot of estrogens, so maybe for the liver cysts, it's not so good to do such a procedure, but I don't think it's such different from a normal pregnancy. So I don't see any great objections there. Then another issue always is medication during pregnancy. There is medication that should be stopped. Often Oscal is acetylsalicylic acid is given to lower your chance of having preeclampsia. And I think specifically for ADPKD, it's good to mention that you probably have an increased risk on cyst bleeds if you give that to women. And here you see this in the scheme that the chances of having hematuria are elevated on acetylsalicylic acid. But I still the risk of lowering preeclampsia prevails. So I still think it's important. But I think these are issues that should be discussed. So if you have my opinion, I would say it's important to inform patients about the option of PGD.
Thank you, Esther. And I will pass the word to Djalila for the pediatric perspective.
So even though I think this is not strictly a pediatric issue, however, we are seeing as pediatricians young parents who are really busy with familial planning, specifically if they have already a child with ADPKD, and more specifically if they have a child with a severe form of ADPKD. I think it has been suggested in the literature that when you have a child with a severe form of pediatric form of ADPKD, the recurrence risk is higher. However, like you see in this cartoon that I published with Stephanie de Richter, we tried to show that the phenotypical variability is very high in ADPKD, including childhood onset, but also including very early onset of ADPKD, mimicking actually ARPKD with this prenatal diagnosis of huge hyperechogenic kidneys, sometimes with already renal cyst and with oligohydramnios, and sometimes with a lethal form. And actually till now, although the genetic testing can be a bit helpful in understanding this variability, we are unable to predict this familial interfamilial variability, but also even intrafamilial variability. And there are few cases published by Carson Bergman where we see this very early onset ADPKD that above the familial genetic inheritance of a PKD1, they might have actually another variant on another ciliopathy gene, or sometimes what we see B-allelic PKD1 transmission. And we try to explain this very severe form. So I would like to highlight this because I think counseling these parents, I had in my clinic that parents were counseled and they had a PKD1 non-truncating mutation, and it was told that that they have the good genes or the good mutation and they can be pregnant without any problem. However, they had a very severe form of a very early onset with really huge kidney echogenic and now a very severe infantile form of ADPKD. So I would like to highlight what Esther said, that the intervention of a clinical geneticist is very important in counseling these patients, that these patients need to know that they have the choice to use PGD, because using PGD is really stopping the disease in their families. However, they need to be very closely monitored, specifically if the mother have ADPKD.
Thank you. And I think that now it is particularly important to hear the patient's perspective about the point. So, Holly, do you want to add something?
Yeah, so this one I'm in two minds of always, because it's something that gets brought up to me every time I go to the clinic about if you're going to get pregnant, you need to stop your tolvaptan, which is obviously a big decision in itself, and whether you would have the option to have IVF or PGD. When I first heard it, honestly, I was shocked that that was even an option. I never considered it. I never thought that it would be something that would be available. But the more that I've learned about it, it's amazing. It's definitely a good thing to be made aware of. I personally don't know whether I would go down that route yet, but I know, for example, my mum, when she was pregnant with me, had a lot of issues because of her ADPKD that started to affect the birth, and we were in hospital for a long time before she gave birth. So I think she definitely would go down this route, but it's another one, like, it's all about discussion, making sure that the patient feels comfortable. Something I think that would change my decision is if I decided not to have PGD and to just conceive naturally, whether the support from midwives or other health professionals would be suitable, because my experience that I've had so far with my polycystic kidneys is outside of my specialty clinics that I've been to, the knowledge has been a bit lower. And for example, when I was in hospital, when one of my cysts burst and they didn't really know about it, they didn't have a lot of information, that would be something that would make me feel a bit more worried. So if I knew that the knowledge of the other medical professionals was quite high on what the risks might be, then I think I would feel a bit more comfortable. But yeah, with the last question, it's definitely just considering their feelings. It's not something that needs to be forced. This is the option that's available for you. If you choose to take it, great. If you choose not to, this is what we can do to help you as well.
Thank you so much, Ali, again. This is a great point. And now we may move to the third question, the last question, which concerns the daily life of our patients, and in particular the lifestyle and diet. And the question is, would you advise on lifestyle in patient diagnosed with ADPKD? Once again, we have 4 choices. The first one, yes, lifestyle including diet is very important disease management of ADPKD. Yes, but lifestyle do not need to be very strict. No, the patient should decide this for his or herself. Or no, lifestyle and diet have no role in the management of ADPKD. What do you think? Okay, yes, lifestyle is important for you, for all of you. But for some of you, it's important to underline that lifestyle needs to be not very restricted. So I would pass the word to Esther for the adult nephrology perspective. Once again, let's start with Esther, please.
Thank you, Fabio. I think on lifestyle in ADPKD, you can have a session of over an hour, I think, to talk about the evidence there is, that things you do. But, well, I try to avoid that and try to be short to also give space for discussion. So here, right, what I do in daily clinical practice, I think it's important to reduce blood pressure and cardiovascular risk. And for that, obviously, a lot of lifestyle issues are proven from other fields, like having a normal weight, do not smoke, things like that. Then if you look at cyst reduction or to keep kidney function constant in ADPKD, I think only for sodium intake, you can make a case that there is evidence for it. So in that, I'm also pretty hard advised that, well, you should aim at a salt intake of 5 to 6 grams. Then there's a strong rationale, but no real evidence yet for things like caffeine intake and increased water intake and a healthy weight. So I advise to do it when feasible, but well, it should also be livable because you have to do it the rest of your life. So in this I advise, but I'm not very strict. And well, as you probably know, there are a lot of studies now going on about things as food restriction, ketogenic diets. And as long as there's no real evidence for this, I do not advise that. So this is how I do it in clinic. But if we have the time, well, maybe we can discuss about that later on.
Thank you, Esther. And now I'll be interested to look at what is the opinion of Djalila and on the pediatric perspective. Please, Djalila.
So for me, as I already mentioned, I think, and as Esther started with the hypertension and the cardiovascular outcome is one of the most important comorbidity in ADPKD. And it has been actually reported that almost 20% of the ADPKD diagnosed children have already hypertension. It has also been demonstrated that there is a correlation between the hypertension and the cystic growth, and also between hypertension, even percentile P75 and left ventricular hypertrophy. So there, next slide. So there we really, as a pediatric community, we recommend that these children need to be monitored for hypertension. The preferred method, we would recommend the 24 hours ABPM, and the first line treatment is ACE inhibition. However, we don't have enough data to strongly recommend lowering the blood pressure even under the P75 or around the P50, but that is really something that we advise in our clinic. For the other dietary and drinking things, I think my answer there is very easy. There is really a lack of evidence in childhood. And there we don't recommend to lower things, but just to follow the recommendation for the general population in pediatric. But it is already very well known that now younger patients or younger children in general often have much higher salt intake than the recommended. So there we really try to get the recommendation for the general population. We start in our transition with our adults, with adolescents, to prepare them for being adult, and we speak already with non-smoking. We try to avoid NSAIDs. When a girl comes to our clinic and she starts thinking about contraception, we advise an estrogen-free contraception, and we really highlight the effects on sports and BMI, even in all the children with a kidney disease. And to close this chapter, I would like really to cite the effort of Tess Harris, president of the PKD International from UK, and a lot of patients, but also a multidisciplinary work has been done to prepare this ADPKD route map, which is made actually for patients, very easy to use, and with several languages that you can use in your clinic, because I think we don't have really a lot of time, unfortunately, for our patients to explain all this. However, we can give them this that they can see in their smartphone, and they can read very useful data. And I thank you.
Thank you again. And at this point, I think that a common mistake is to prescribe restrictions, for example, as regards to diet, without looking at what happens in the daily life of our patients. So it's important to hear their opinions, and so I will be very, very interested to hear the opinion of Holly about that point. What do you think, Holly?
I think, as lifestyle goes, it's nothing that no one else should be doing anyway. Exercise, low salt, high water, not smoking, not drinking too much. So I think as lifestyle changes go, it's very, very minimal, so very, very manageable. So I don't think that the word strict could be used ever to describe this. In my own personal experience, the only thing that really I've had to adapt to is drinking more water, and that's because I'm on tolvaptan, and obviously you have to increase it by a lot. But I'm sure you've all seen me sipping away lots already. It makes me very thirsty. It's very easy to drink a lot of water. But other than that, it's just general lifestyle advice that most people should be following anyway. So I think in that aspect, we're actually very lucky that there's nothing too major that we have to cut out. So yeah, I think it's definitely not strict, but it is definitely important to highlight the things that we should be doing.
Thank you again, Holly. And we are following time, so maybe we can now start our discussion. Maybe I stop sharing the screen and start with an open discussion, all of you.
Shall I add 2 comments, Fabio, before maybe you start with a question from the audience? I'd like to thank all speakers, of course, and you, Fabio, for this wonderful, full of information e-seminar. 2 comments about pregenetic counseling in women. So in some countries, we have to inform them in advance because, for example, in UK, NHS is funding that if it's the first baby for a woman who decides to do that before the age of 40. So it's better to know that, because if the woman gets older than this age, or if she decides to go for natural way for her first baby and then decide to go for IVF for the second baby, it won't be funded by the national healthcare system. So depending on the country as well, these things might change, but I think it's important to have all the information ahead, and then it's up to them to decide what to do. Yeah, that was just a short comment with regards to that.
Okay, there is a question from the audience for our speakers, and the first question is concerned to the role of exercise. What do you suggest to your patients concerning exercise? This is both for pediatricians and adult nephrologists as well. So maybe Esther, would you comment on that, please?
Sure. I think in general, exercise always good for any chronic kidney disease. So like having a healthy weight, also exercise is important, I think, to reduce cardiovascular risk. So yes, I think that's something we should advise.
For me, the question rises.
Djalila, you're muted.
Yeah.
So for me, the question is which sports by the discussion of the children in my clinic, because of course, doing sport, the main, specifically in Belgium, but maybe in other countries, sport is in the daily life very, very good. But may I do kickboxing? May I do such sport with the risk of a traumatism in the abdomen? And that is a very tricky question, because I would like, or soccer or handball or something. Actually, my advice is always, if you like this sport, you need to go and to realize your dream, because I think sport is very important. And if they like this sport, they need to do it. Sometimes I advise, like for soccer, or when you have a ball or something, to use a protection for the abdomen for the children who have this huge kidney with huge cyst. But I would like to hear Esther, her opinion on which sport would you really avoid when you have this huge kidney. Is there any things known on other?
Yeah, this is all not evidence-based because numbers are that small, but I definitely have patients who had increased hematuria after things like kickboxing. So for these patients, also if they have a lot of cyst bleeds that are a problem, yeah, you'd say try to avoid contact sports. But I would not start with that. I think if that's something that people really enjoy and there are no problems, I wouldn't say that in advance.
Thank you so much for your answers. Please, maybe, please don't be shy. Please ask your question, and I will share with our speakers. There is questions concerning 24-hour blood pressure measurement, specifically in a teenager, but probably in all the patients with ADPKD. So what do you suggest as to check blood pressure in children? 24-hour blood pressure, how often? And I would add, do you check for echocardiography maybe, or home blood pressure? What do you think about it? In this case, we will start with Djalila.
So there we wrote recently also with Charlotte Gimpel and Franz Schäfer a consensus paper where we included pediatric adults, geneticists everywhere. And the discussion was there very clear and based on a very large study done by the Italian group of Laura Masella, who did ABPM in European pediatric cohort. And we demonstrated indeed that ABPM will very important in this population because we can exclude white coat blood pressure and unnecessary treatment. And we demonstrated also a very interesting pattern of a non-dipping nocturnal hypertension in this population where we are exploring now. So I would recommend at least once an ABPM to be sure about diagnosis before starting treatment. Home blood pressure is an option for follow-up. How often? If you have a hypertension, of course, you can follow up this yearly. However, if it is not, we recommend it each 2-3 years. But that is not evidence-based, it is a recommendation and consensus from experts in the field.
Thank you so much. Would you like to add something, Esther, or maybe Holly? Do you have any comments about that?
I don't know, Holly, do you want to go first? Do you want to say something?
No, I didn't have any comments.
Okay.
Thank you. So we have some questions.
Maybe I could add something, Fabio, because I think there are two important issues. The first is what should be the target blood pressure, right? Because there are a lot of studies performed also in ADPKD, whether we should maybe have 130/80 or whether we should lower this, as you might know, in the whole studies, which failed to show that a lower blood pressure was in fact better. So the question is, how strict should we be on blood pressure, also because it's part of daily life of patients, and it should not be an obsession to start measuring blood pressure also, I think, in childhood, because stretching differences between pediatric nephrologists and adult nephrologists, I think we might be a little more relaxed on the blood pressure. At least that's my experience from patients I get referred from our pediatric nephrologist. And what I do with blood pressure is I strongly advise to measure it at home, because that also makes patients aware of their blood pressure and makes them better adhere to a salt-restricted diet. So, and also maybe because of the COVID pandemic, where we did more video calls and more phone calls, now almost all my patients have a blood pressure measurement at home, and I rarely do it actually in the outpatient clinic.
Thank you so much. We have some questions, some other questions for the audience, and in particular 2 questions concerning the diet again. So diet suggestions for people with EPKD and avoiding kidney failure by nutrition. These are 2 questions. What do you think about this? Maybe.
Could you repeat the question? I didn't hear it well. Sorry.
Yes. So 2 questions from the audience concern the diet that you prescribe to your patients. So one is a general question concerning dietary suggestions for people with EPKD. We have talked about sodium, but maybe you have some other points to add. And the other question is concerning the possibility of avoiding kidney failure by nutrition. What do you think?
Hey, Fabio, I don't know if you can put on some reserve slides that deal with this question.
Yes, I can. Perfect. Can you see the slides?
No, but maybe that's my fault. I don't know if other people can see it, then it's okay.
Yeah, we can see it.
We
Okay,
can see.
maybe I clicked on something. Oh yeah, yes, now I see. Now I see the slide. I'm trying to make it a little bigger. Yeah, because this is actually a recent article Ron Gansvoort and I wrote on the summary of dietary advices after reading all the literature. So for salt intake, we already discussed about that. I think for protein intake, we should avoid a too high intake and only have a protein restriction in case the eGFR declines to prevent uremic complaints. Well, we talked about smoking and about the healthy weight. We said to moderate caffeine and alcohol intake. And well, the discussion about fluid intake is hard because it's not really evidence-based, but what we say is to target for a low urinary osmolality. And well, discussion remains how low is low and when should you do this? Well, we think you should go as low as possible when the eGFR is still good, so above 60. And when the eGFR is lower, I would be thoughtful with additional water intake, because you also then have a problem with diluting your urine and you're more prone for a hyponatremia. And also I think the benefit will be less. So when eGFR is below 30, I wouldn't advise actually to really drink more water.
Perfect, thank you. Any other comments?
So may I have some comments and questions? Yeah, so I would like to thank you for your presentation. I liked all of those very much. It was very interesting. And at the very beginning, I would have liked to ask for the presenters about their clinical practice related to the transition. So how is it structured in your practice? You know, when a patient goes from the pediatric to the adult care, are there any specific structural, logistical road to for the patients? And now I would like to add another question for Holly about how do you live, how did you live in this situation when you just changed or transited, or you know, from the pediatric to the adult care?
I wasn't part of any pediatric care. I wasn't diagnosed until I was 25 or 26. I had some kidney issues when I was younger. I can't remember that much about them, to be honest, but my mum used to describe it as a baggy kidney, is what she's told me I had, which I don't know what that means. So I never really dealt with anything pediatrically. The adult care has been very good. I go to a kidney-based clinic once every 3 months at the moment. Prior to COVID, it was more regular, but that's fine. I get tested for bloods, urine, have a chat with the whoever's on the clinic that day. I've only had to have one scan done, but I can't really comment on the pediatric care, but adult care has always been very nice and very good. Not just saying that because Jenny's here either.
Thank you.
Thank you, Ali. Thank you so much. Okay. I've been up. Oh.
I don't know if Esther would like to
Sure. What we do for actually all patients who transfer from pediatric care to adult care is that we have a regular meeting every month where these patients are discussed. And then specifically for specific diseases, as for ADPKD, most of I see them together with a colleague. So then we get specifically a phone call about these patients. So there's, for all these patients, there is a moment where we pass on information. How do I know how you do it in your clinic, Djalila? But probably you have the same work.
So for us, we have also a program of transition on the renal genetic disease where we are meeting with our colleague adult once monthly. However, the ADPKD, because they are my babies and it is my research section, and actually opened the transition clinic the same day in ADPKD dedicated, and one adult nephrologist come to the pediatric and they see them in the same corridor where they are used to, where the nurses are known, and we try first to get the parents out, because that is one important step in transition, because we are always used to speak to the parents. However, the adults speak directly to the adults, and the parents sometimes have more difficulties with the transition than the children by their own. So, and then the parents stay discussing with me or with the nurses, and that helped them for the transition. And actually, when they became 25 or something, then they go to the adult department.
Thank you. Thank you. That's an important point. Another, we have some other questions from you, and one concerning the role of magnetic resonance imaging. And the question is, should we do magnetic resonance imaging to follow kids with ADPKD? At what age should we start? This is a very debated point.
No, I don't think it's debated. My question would be straightforward. No, we don't do MRI in childhood. We are using MRI in childhood only in clinical trial, really, to really assess the treatment. However, it is really not needed for the follow-up of these children.
Very clear point. Thank you. Another question concerning the treatment. In that case, metformin, but maybe we can talk about the new drug for ADPKD. Is it, in that case, metformin, is it time for a phase 3 clinical trial? What do you think about the treatment options for ADPKD? Maybe Esther.
Well, I think after the TAME study that showed that metformin was bearable for patients, it is time for a phase 3 study, because, well, as you might know, the TAME study was a phase 2 study that was only looking whether it was tolerated and not really for efficacy. Efficacy was looked at a secondary endpoint where there were actually no differences between metformin and placebo treatments. But you could argue that the study was not powered for it. It was relatively short time, not much patients, and also not enriched for disease progression. So it would also be hard to find. Well, on the other hand, well, we saw in animal studies that metformin did it really well, but we've seen again and again that medication from animal studies did not show really results in clinical studies. And I'm also afraid that for metformin, the dose that equals those that are given in animal experience is not tolerable for ADPKD patients. So I don't know whether metformin will make it. I doubt it, to be honest.
Thank you. I don't know if you have more time, or do you want to add anything or any other questions or comments?
I guess that we can have some more time, and we have 3 more questions. And after the 3rd question, we could maybe fulfill our dedicated time. Yeah.
Okay. Do you recommend genetic testing in healthy parents of children with proven ADPKD and negative family history? Do you want to answer?
You want to know. I think if it depends also on the age, but if the parents, do not have any signs on an ultrasound, I think it's very unlikely that they have a genetic mutation.
Actually, I would add something. It depends on the age of the parents, because a proven genetic ADPKD in a child with a very young parents, or 25 or 30, who never had an ultrasound, we cannot be sure that he don't have ADPKD. So it depends on the age. Second thing is, sometimes we find with a child with renal cyst with some variant of PKD, where we are not aware about the pathogenicity of these variants, and we cannot be sure about diagnosis. So doing genetic in these parents might help the interpretation of the genetic results of the child.
Thank you.
Fabio, can I add something on Djalila's comment?
Obviously.
So apart and on Esther's comment, so apart from helping the parents know if they have it or not, so they might need treatment in order to avoid end-stage kidney disease at an early age, and from upgrading the mutation, as Djalila mentioned, because we might need further data to be able to properly label it as pathogenic, then I think it's important if they are keen on having more children. So for these three reasons, I think it's important to discuss genetic diagnosis with families.
Thank you. Thank you for this important observation. I'll move to the next question. Have any of you observed an increase in congenital heart disease in patients with ADPKD? Kibib Leagues published some data on these, and the question is specifically for Djalila.
Yeah, so indeed, it was the publication of this week. I think the Mayo Clinic evaluated all their adult population, I think more than 1,300 patients, and they went and looked that the congenital heart disease was like 1.4%, if I could remember, but I was not prepared for this question. More than the general population, which is much lower. I must say, of course, ADPKD is a very common disease. We have some valvular pathology that we are seeing in patients and in children. However, we are now currently, so as the main pediatric nephrologist knows, with the pediatric community working of a very nice initiative, which is the ADPKD registry, where we are getting data from children with ADPKD from the whole world, from all the continents. We have already included 1,300 patients, and the numbers are increasing, and we will soon evaluate this and confirm these numbers.
Great, thank you. Another question concerns the use of tolvaptan in children with ADPKD.
So we did a trial on tolvaptan in children. So we started inclusion from 4 years till 18 years. It was actually a 3 years trial, with the first years placebo randomized, and the 2 next years were open label. So we are now closing the last inclusion. However, I presented already the first year of the trial. So the trial, it was not powered to assess efficacy, but mainly powered for safety. And the first year of the trial demonstrated a safety effect. However, with, of course, a very important side effect of polyuria and polydipsia, where children were drinking and peeing sometimes even more than adults, even 7 liters, which for their daily life and really for the school age, it is really a very important issue. However, I must say, as I participated in this study, I was really, really surprised that the children who participated in this 3-year study wanted to continue off-label use of tolvaptan, because they have the impression that they are acting on their disease. And it was also shown in the results of the quality of life of this trial. The quality of life was improved in the tolvaptan arm compared to the control. And we don't know how to explain these results, but we need to follow up this.
Thank you so much for this answer. And then we have another last question concerning the ACTION trial. What do you think about that? Maybe we can ask Esther to an opinion about that.
ACTION trial?
The ACTION trial sponsored by Palladio is the question.
I'm sorry, I do not know it. Do you know it, Djalila?
No, maybe we should, maybe Kevin, maybe you can send more details on this ACTION trial. It is on adult, I don't know. I am Palladio. Which company is this, Palladio?
So what I can say is that it's already registered on the clinicaltrials.gov site, and it's basically testing the efficacy and safety of lixivaptan in the treatment of ADPKD.
Okay.
Yeah.
Thank you.
Thank you, Jenny. Yeah, lixivaptan, for people who don't know it, is like tolvaptan, a vasopressor V2 receptor antagonist. And the idea of lixivaptan is that it does not have that hepatotoxic profile that tolvaptan has. So that's the idea about the trial. And in my opinion, the problem with the toxicity, it exists, but not in that many patients. So I don't think it's the largest problem with vasopressin receptor antagonist, which obviously is polyuria. This trial, well, I think, well, from hindsight, maybe it would be better to include patients who had hepatotoxicity on tolvaptan, because these are the patients you're interested in. But that's not how the study is set up. It's set up comparable to the TEMPO study, which was made for registration of tolvaptan. It's a very large study, again, looking at lixivaptan and the efficacy on kidney function decline and kidney growth. So, well, if I could make the trial, I would make it a little bit different. I don't know if that's an answer to your question.
Thank you. It's probably time to go to the closing remarks. And first of all, let me thank you and asking Holly if she has something to add, any comments, and let me thank you for having joined us today.
Thank you. It was interesting to hear some different perspectives from people as well. Not many comments on my side, just as we said with many of the answers to the questions, the importance of the discussion with the patient rather than sort of, this is the way, needs to be open, decide what they want to do. Some people are the ignorance is bliss sort of mentality. Some people prefer to know and know what's happening to them. So yeah, I think just be as personable with your patients as possible and everything will be fine.
Thank you so much.
Thank you for having me.
Thank you. And so I would pass the word to Jenny for...
Thanks, Fabio. Thank you all for this meeting today. I think it was very educational regarding ADPKD, and I think it was very meaningful because it gave knowledge that someone cannot find just in textbooks, but wise advice from clinical experts in those clinical challenges we're all facing with these patients. And then I think it was hugely important, Holly's opinion, because it's very powerful having patients saying what they feel. So for us as clinicians to be guided on what is important from their view. And I really hope that patients' perspective will be more and more incorporated in, further meetings, because this is something that is not only changing clinical practice, but should be the driving force behind future research for better treatments and different ways of managing them. So that was my basically concluding point. I would like to thank again everyone, and especially ERA young nephrologist who hosted this event with us. And I will just give the word to Orsi to finalize that e-seminar. Thank you.
Jenny and all the others who presented here today, thank you very much. And I also would like to thank for our coordinator team to letting us possible to this e-seminar. Thank you very much for the speakers for accepting our invitations. Thank you, Professor Mekahli and Professor Meijer. Thank you very much for you. For today's seminar. So I sincerely believe that a regular communication will begin between our professions. I mean, the adult and the pediatric nephrology, because it's very important. This platform is very important. And I guess that today's, let's say, success further underscore the importance of transition between the pediatric and adult care. So here, I would like to close this seminar, and the opinions of our patients mirrored back for us lively, you know, which what we are doing is useful or not. But because what we're doing in our everyday practice, daily teaching, research, and our healing work is ultimately serves them. So I guess that I would like to close the seminar by those words, and thank you for having joined us today, and have a lovely evening. Thank you very much, all of you, for joining us. Thank you.